So this is probably my favorite presentation of all time. I resurrected it from March of 2014. It's called Adrenal Insufficiency, What is it, what it looks like, and what we can do about it. We're going to look at anatomy and terminology, the renin-angiotensin-aldosterone system, stress responses, pathophysiology of adrenal insufficiency, risk factors for acquired insufficiencies, Addison's disease, diagnosis, acute adrenal crisis, treatment both long-term and for the acute crisis, and then EMS role in adrenal crisis. So looking at the endocrine system, which is a series of glands, we're going to look at three in particular. We're going to look at the hypothalamus, the pituitary, and the adrenals. And we're going to talk about some hormones in particular. We're going to talk about cortisol, aldosterone, ACTH, and ADH. So looking at endocrine anatomy, the adrenal glands have two components, the medulla and the cortex. The medulla produces non-life essential hormones such as epinephrine and norepinephrine. The cortex is life essential. It produces cortisol and aldosterone. And the pituitary is the master gland. It is the control module for the other hormone glands. So why are cortisol and aldosterone life essential? Cortisol regulates blood sugar, and aldosterone regulates blood pressure. And what does the brain need to survive? Oxygen and glucose. When the blood pressure drops, you get hypoperfusion, which starves the brain of oxygen. Cortisol inhibits insulin production. You have blood sugar problems. So let's look at the renin-angiotensin-aldosterone system. You have the liver excreting angiotensinogen. You add renin, you get angiotensin 1. You add angiotensin converting enzyme, you get angiotensin 2. You add aldosterone, you get tubular reabsorption of sodium, you get excretion of potassium, and you get water retention. You also get arteriolar vasoconstriction and increase in blood pressure. So ACTH, adrenocorticotropic hormone. It's a hormone produced and excreted by the anterior pituitary, which increases corticosteroid production and release. Cortisol is a steroid hormone produced in the adrenal cortex, whose primary purpose is to increase blood sugar, suppress the immune system, and aid in the metabolism of fats, proteins, and carbohydrates. Aldosterone is a steroid hormone produced in the adrenal cortex, whose primary purpose is to regulate blood pressure. It does this by conserving sodium in water and excreting potassium. What is stress? Stress is defined as a physical, chemical, or emotional factor that causes bodily or mental tension and may be a factor in disease causation, whether it be an injury, an illness, an emotional factor, or an environmental factor. How does the body handle stress? Your heart rate increases, your respiratory rate increases, decreased GI motility, the liver releases glucose for energy, the hypothalamus stimulates the pituitary releases ACTH, ACTH stimulates the adrenal glands to produce cortisol, cortisol enables sustained blood sugar to cope with the stressor. So in adrenal insufficiency, there are disorders that impair the adrenal gland production of steroid hormones, primarily ACTH, cortisol, and aldosterone. This causes a loss of appropriate stress response, causing blood sugar regulation problems as well as blood pressure regulation problems. These people are commonly found hypoglycemic, hyponatremic, and hyperkalemic. There's a 2.7% mortality rate in those with adrenal insufficiency, with 24% resulting from adrenal crisis and 33% from endocrine complications. There are three types of adrenal insufficiency: primary, secondary, and tertiary. Primary would be Addison's disease, congenital adrenal hyperplasia, and things like that. Secondary would be pituitary impairment, caused primarily by long-term steroid use. And tertiary would be due to hypothalamic disease. So let's look at some risk factors for adrenal insufficiency. Respiratory disease with prolonged steroid use. Be suspicious in people who have chronic respiratory conditions that are non-compliant with medications and have been on steroids for a prolonged period of time and then suddenly stop. Skin conditions with prolonged steroid use, fad diet pills, cancer patients, tuberculosis, AIDS, fungal infections, hemochromatosis, hyperthyroidism, pernicious anemia, and bilateral pheochromocytoma with adrenalectomy. Addison's disease was first discovered in 1855 by Dr. Thomas Addison. The most notable Addisonian president was President John F. Kennedy. The frequency is approximately 1 in 100,000, and it typically manifests between age 30 to 50. It's caused by underproduction of steroid hormones by the adrenal glands. Initially characterized by vague symptomology such as lethargy, pain in the legs and abdomen, vomiting, diarrhea, dehydration, then it progresses to more serious symptoms such as hypotension, sometimes orthostatic hypotension, syncope, hypoglycemia, confusion, stroke-like symptoms, convulsions, fever, hyperkalemia, hypercalcemia, and hyponatremia. They retain excess potassium, excrete excessive amounts of water and sodium, the term salt wasters. These are people we may see frequently, and they can become very sick very quickly. Most people with Addison's have a medical alert bracelet. They carry their own emergency medications. They carry emergency instructions. They may crave salt or salty foods, and they may have hyperpigmentation spots. These are the hyperpigmentation spots. You can see the dark areas. So Addison's disease, easy to diagnose and treat if you think of it. 90% of cases are an autoimmune disorder which causes the body to see the cells of the adrenal cortex as foreign and reject and destroy it. TB can destroy the adrenal cortex. That was originally the largest cause of Addison's disease, and treatment with rifampicin can cause an Addisonian crisis. Due to the vague symptoms, Addison's disease can go undiagnosed for years. It's generally caught by practitioners that notice patterns in patient presentation. This is why EMS providers are key in a role to identify these patterns. The ACTH test happens when synthetic ACTH is injected and blood levels are tested at 1, 4, 8, and 24 hours. Normal cortisol levels should be reached by the 4-hour mark. Those with Addison's disease will have low levels consistently, and those with secondary adrenal insufficiency will have a delayed response, but once achieved will be normal. Ongoing treatment is focused on replacing aldosterone and cortisol, maintenance dose of PO, hydrocortisone, or prednisone, which provide an artificial mimic to cortisol. Florinef, or fludrocortisone, replaces aldosterone. Hydrocortisone is used to replace naturally produced cortisol and used to promote blood sugar regulation. It's short-acting. Florinef, or fludrocortisone, has high mineralocorticoid properties and therefore causes retention of sodium in the kidneys and excretion of potassium and hydrogen ions. It aids in blood pressure regulation and is very long-acting. This is the Addison's crisis pathway, and when you look at it, you'll notice one thing. All pathways lead to shock, brain, and coma death. So here you start out with some type of dysregulation, whether it be cortisol, dysregulation, adrenal glands not functioning, or aldosterone not functioning. Then you have some sort of malfunction, whether it be liver function, stomach function, kidney function, or heart function malfunctioning. You have low blood sugar, vomiting, diarrhea, low fluid volume, low blood pressure, extremely low blood sugar, and then we end up with shock, coma, and death. All pathways lead to coma and death. Acute adrenal crisis is life-threatening without prompt recognition and treatment. Traditional therapy will not resolve the crisis without treating the underlying condition, but it can buy time. Small stressors to an unaffected human may be fatal to an affected individual. They may present with signs of severe shock without other obvious cause. Severe nausea and vomiting can rapidly become fatal. They may be hypotensive, hypoglycemic, and show signs of hyperkalemia or any combination. 1 in 500 people are at risk for some sort of adrenal crisis at some point in their life. So if you think about how many patients you will treat in a career, you may see this several times over. So when I put this presentation together, Ebola was the big thing at the time. So I put E as not just for Ebola. When we look at AEIOU tips, the causes of altered mental status, E is for electrolyte imbalance or endocrine disorder, including blood sugars. So what will these people look like? When in true crisis, they'll present hypotensive, hypoglycemic, and they will have signs and symptoms of hyperkalemia with EKG changes. So let's look at an EKG of someone with hyperkalemia. We have the sine wave. We have the peak T waves. So that person is hyperkalemic. So what can we do? Currently, we don't have a protocol to deal with adrenal crisis. We want to give them large volumes of fluid, saline or D5. Give them D50 to correct the hypoglycemia. Give them IV or IM steroids, and we'll go into what that looks like, because it's not traditional dosage, and treat life-threatening electrolyte imbalances. So if they're hyperkalemic, we want to treat the hyperkalemia. So steroids. Solu-Cortef is the preferred, and generally it's carried in their crisis kit. Solu-Medrol is an acceptable substitute, but it's at a lower dose than used for respiratory or allergic reaction. 20 milligrams or 2 milligrams per kilogram, max of 20 milligrams. Solu-Medrol equivalent, and that's equivalent to 100 milligrams Solu-Cortef. Any higher doses will suppress the immune system and be counterproductive. Solu-Medrol takes approximately twice as long to reach peak effect, so care is aimed at life support until the body reaches homeostasis. Dexamethasone is also an option, 4 milligrams IV. So take note of that dose. It has no mineralocorticoid properties, so it does not distort the ACTH tests. So that is a benefit of dexamethasone. It will require electrolyte support, so the treatment of hyperkalemia, hypoglycemia, and hyponatremia, and it has the same time concerns as Solu-Medrol. So it takes approximately twice as long to reach peak effect, and so you'll have care aimed at life support until the body reaches homeostasis. So the big debate is, are other steroids an acceptable substitute for Solu-Cortef? Many countries use Solu-Medrol as the primary home emergency treatment for crisis, including the UK and Australia, not Solu-Cortef. Solu-Medrol takes longer to reach peak effect and contains slightly less mineralocorticoid properties. With effective supportive care, patients can be stabilized until Solu-Medrol or dexamethasone starts working. The 2003 Stanhope study in London showed the vast majority of people who are on steroids at home can receive appropriate supportive treatment without steroids in the acute crisis setting, which is electrolyte and blood pressure management. So we're going to look at the steroid chart right now. So here we have Solu-Cortef versus Solu-Medrol versus dexamethasone. And this is the equivalent dose, mineralocorticoid properties, and the duration of action. So we see how long it takes to reach plasma concentration. and then how long it acts. So dexamethasone lasts substantially longer than either of the other two. It reaches plasma concentration in about the same amount of time as solumedrol, and then we see the equivalent glucocorticoid dose. So, what drug do some EMS services carry that could be potentially fatal if given to an untreated adrenal crisis? And StatFlight carries this. Etomidate. So if we have someone who we suspect an adrenal crisis and StatFlight's going to give them etomidate, we may want to speak up. It's been found to cause fatal adrenal suppression with just one dose in patients with sepsis unless treated with steroids. Etomidate can send those with insufficiency into fatal crisis if used without pre-treating with steroids. So let's look at a case study. We respond to a nursing home for a 72-year-old male with altered mental status. Our initial assessment shows he opens eyes and moans to painful only. Per the nurse, his mental status has been declining over the past 8 hours. Baseline is alert and talkative. Airway is patent, breathing is rapid and shallow. Radial pulse is weak but present, regular, normal rate. Skin is warm and dry with poor turgor. Blood sugar reads low. Blood pressure is 60/40. Pulse is 80 beats per minute and regular. Respirations are 28, 98% on room air. End tidal is 28, rapid and shallow but otherwise normal waveform. Temp is 101.5 rectally per the nurse prior to arrival. And let's look at the 12 lead. So we see those sine waves, we see the peak T waves, so we're thinking hyperkalemia. So the signs and symptoms are altered mental status, hypoglycemia, fever, diarrhea, and vomiting. Allergies to tetracycline and aspirin. Meds are Cortef and Florinef. History of Addison's disease. His last oral intake was nothing in 24 hours, told the nurse he wasn't hungry. Events leading up to the illness, vomiting and diarrhea, fever and weakness for 24 hours. So what problems do we see? Hypotension, hypoglycemia, electrolyte disturbances. So initial treatment. IV with a bolus of D5 or normal saline, D50, dexamethasone 4 milligrams IV. And does he fit the profile for treating hyperkalemia? I'd say absolutely. So calcium 1 gram, bicarbonate 1 milliequivalent per kilogram. So EMS considerations. Remember, we can play a key role in recognizing those who are potentially adrenal insufficient. Remember, we'll suspect possible adrenal insufficiency in patients that have suddenly had a lapse in chronic steroid use. Glucagon will not work due to a lack of glycogen stores. And most of all, keep calm and give steroids. I hope you have enjoyed this presentation as much as I have.